Hey everyone, welcome back to my channel. It's Rachel. I didn't really announce this one what time, so I don't know how many people will be able to jump onto this. So for those that can't join me live, thank you for watching later. So for those that don't know me, I'm an emergency physician. I work in San Antonio, Texas. And if you are just not paying attention to the world right now, COVID is going kind of crazy in Texas, actually pretty much anywhere in the South. And, I've been kind of doing these updates a little bit more regularly since we took off here in San Antonio. And so I wanted to update you guys how things are going. It's been a really rough week. And I'm going to try to read comments as we go along. So, hi, Reviews with Sue. So, yeah, it's been a rough week here in Texas. We are no longer the number, I think, 4 or 5 hotspot anymore. We're still up there in the top 20, but our numbers have slowed down a little bit. But our patients are getting sicker and our hospitals are pretty much near capacity. We're predicting maybe another week and a half when we start having to go into disaster mode. They're actually prepping our Coliseum with a hospital, like makeshift hospital to put overflowing patients. So it's getting bad here. So I like to start this with just kind of going over, hey, Stephanie Short, I like to start this by going over the overall numbers so you guys get a grasp of it. And then I start kind of going through like therapies, where we're at, that kind of stuff. And then if you guys have questions, I'll try to answer them. If not, you can leave them down. And then my next update, I try to go over them. So basically in the world, there's about 11 million cases of COVID. That's a lot. In the US, we are over, I wanted to say we were over 11. No, what were we? Over 2 million, I believe. We're about at 2 million is what I was looking at the last data. In Texas here, we're over 200,000 cases. That's a lot. Now, we're a big state with a large population, but that's still a lot. We're about 2,700 deaths, which doesn't sound very big, but our death rate is going up. And I'm going to go over like theories and things in the news media that people are hearing here shortly as well. So we'll talk about death rates and whether they're rising or lowering here in a minute. So in San Antonio, we have officially gone over 15,000 cases, and our deaths, we had 5 more today, so we're up to, I think it's like 130. But I can tell you that daily our death rate is going up, and it's probably going to get pretty bad here shortly. So, yeah, the numbers are not looking great. Our doubling time has extended out. We were doubling close to every 10 days. We're now doubling about every 13 days, which is still not great. And so that is really, really scary. So in the ER, what am I seeing? Specifically in San Antonio, I work in a community ER. I am seeing a lot of COVID, a lot rolling through my door. I'd say 3/4 of my patients have COVID, and I'm not able to test everybody. We are short of testing. So a lot of the theories rolling around is, oh, well, we have more COVID because we're testing more. Yes and no. We are not testing more because we're running out of tests. And pretty much most of the hotspots, my friends in Houston are saying this, and other places that are hotspots like Central California, we don't have enough tests. So if you are going home, I really can't test you for COVID. If you are, asymptomatic and you got exposed, I can't test you for COVID. A lot of places in our city, and I know in Houston as well, and I think Austin as well, are not testing asymptomatic people who are exposed. We just don't have the testing capability. The other thing that when we say, okay, we know this is rising and it's not just due to testing, is you look at the positivity rate of testing. We were kind of hovering in Texas around like 6% for a while, and that's not bad. But now that this has spiked up since mid-June, our rate is closer to, I think it was about 15% I last looked, maybe 12%. So that's an increase of the test we're doing. A lot more people are positive. And I suspect that rate will go up because we're getting more limited on our testing. I can tell you that I am admitting several COVID patients a day on my shift. I work 8 to 9 hour days most days. And yeah, it's It's a lot. And they're getting sicker. That's the other thing that I'm noticing. When I first started seeing an uptick in our cases, I'd been gone for 2 weeks on vacation. When I came back, we really started having a huge uptick of COVID. And I was seeing 3/4 of my patients, and I was admitting 3 or 4 a day. I'm still admitting 3 or 4 a day, but the ones before were maybe needing a little bit of oxygen, not that sick. And I am now seeing people that terrify me. And when I say this disease state is really bad, I actually really mean it. So, to give you guys an example in this last week of what I've been seeing, I saw a gentleman who was just dropped off. We don't allow visitors anymore because we have so much COVID in our hospital. We had a gentleman that was dropped off, older gentleman, who only chief complaint from his family was that he was weak. He wasn't eating or drinking. And we get him back to the room, and he says, I can't breathe. I don't feel like I can breathe. No fever, nothing else he's complaining about, completely talking to me, acting as if everything was okay except for he felt short of breath. And I put him on the oxygen monitor, and he was saturating 33% on his pulse oximetry. Now, a normal is 95% or above. 33% is incompatible with life in most cases, and you just don't see that. And I put him on what's called a non-rebreather, which is a device that pushes a whole bunch of oxygen into you really quickly. And he slowly came up. And then, not an hour later, I had another patient who was a known COVID patient that came in, saturating in 50%. He was struggling to breathe. I put him on the non-rebreather. He barely came up. I had to put him on BiPAP, and he slowly came up. These patients are rolling in. My husband worked an overnight shift later that night, and he said he had several of those. The amount of patients that are ending up on ventilators in our hospital is exponentially going up. The amount of devices I have to use to keep people off ventilators they're all getting used up. And so that's really scary. Our patients are also getting older again. So initially when this upticked, we were seeing a lot of younger people, 20s, 30s. Those are the folks that were like, I'm fine. I'm going to go out, not wear a mask, go see my 20 friends. The problem is now those 20-year-olds have passed it on to their elderly grandparents. And now I'm seeing a lot of 50s, 60s, 70s now. I'm still seeing 40-year-olds and 30-year-olds that are really sick, but I'm seeing a lot of that slightly older population coming in. My hospital tends to get a lot of elderly because we have a lot of nursing homes nearby. So I wasn't totally shocked to see a slightly older population, but they're sick. They're really sick. And the most terrifying thing is it's now gotten into, at least I know of, 3 or 4 nursing homes within my small area around my hospital. That's only going to go up. I mean, it doesn't take much. And then once it gets into these places, it spreads like wildfire. So, yes, we've had our nursing homes locked down here since the beginning of this, but it is just it's awful, guys. It's awful. So, you know, for those that think that this is a hoax or that they can get really seriously ill, I wish, because I feel so completely helpless as a physician, to make these people better. And we do have more modalities to help these folks, but it's limited. I can give Decadron, I can give remdesivir, which is very, very hard to get. And then we're doing a lot of convalescent plasma, which, if you know you've had this, please, please, please go donate. Those therapies we know we work. But this is a terrible disease, and it is not the flu. The more I see it, it is not the flu. So yeah, that's what I'm dealing with. It's been rough. So I come home, I'm utterly exhausted. I wear an N95 the whole day. I take one break to go sit in a quiet room by myself and eat my lunch and drink a whole bottle of water, and that's it. I don't take my mask off the rest of the day. My face gets, you can't really see it right now because it's been a day since I've worn it, but I get bruising and redness, and it's painful all along here. And it hurts. The mask hurts my face, but I wear it because it keeps me and my family and my patients safe. I even posted a picture of this on my personal social media to try to convince people that it's okay to wear a mask. I know they're uncomfortable, but it's so important. We know that masks work. But yeah, so that's what I'm dealing with. So let's talk about, so I talked a little bit about treatments. Really, we haven't had any big breakthroughs on treatment recently. Okay, so there was one article that came out about hydroxychloroquine or Plaquenil. this has been a controversial drug from the get-go. You know, it was obviously touted by the president. And then they did a bunch of studies. There was like an initial study that showed it might be helpful, and then a bunch of studies that basically showed that it was harmful. There was a new study that came out by Henry Ford that showed promise, but the problem is it's a horrible study. It wasn't done well. It's retrospective, meaning they looked back at groups of folks that had gotten it, and the problem is they're comparing apples and oranges. And so them saying that it showed improvement is really hard to prove because the groups are uneven, and then there's confounding factors like they gave Decadron to some of these people. And so, yeah, it's not a good study. Most of us in the medical world would not give hydroxychloroquine. And it's frustrating to basically have that brought up again. I've had patients that argue with me that they should get it. And I'm like, it's really not a good drug for what we need. Yeah. So the other thing that we're seeing in the news media as a physician, it's really frustrating is there's this argument that we're getting paid more for COVID, that we're getting told to write COVID as a diagnosis code, that we're falsely diagnosing people. And I can tell you that's not the case. I get paid the same regardless of whether or not I diagnose someone with COVID. Medical billing is very complicated. It is based on complexity of a case and, you know, how many elements I fill out in a chart. And if it's a certain complexity, it's a certain complexity regardless of whether it's COVID. The actual diagnosis doesn't make a big difference in the coding scheme. There are certain diagnoses we make that will never get a higher level of coding, and COVID is one of those that can get a higher level of coding. But if I don't put the elements in my chart that are needed, I won't get the higher level of coding. And there's not a magical code that's higher for COVID. We don't get extra money. CMS, I believe, is paying hospitals a little bit more for COVID, but if you look at the grand scheme of how long COVID patients stay in the hospitals are still net negative on what they're getting from COVID patients. So the COVID patients tend to stay in the hospital prolonged courses in ICU 10 to 15 days. They're not getting paid the amount of money that it's taking them to keep these patients in the hospital. So when they say CMS is paying a little extra for it, yes, but in a total whole, hospitals aren't making a fortune off these. They're actually losing money. They make more money off doing elective cases, which they have to shut down when COVID goes crazy. So if anybody's in the know on healthcare, they know that you don't want a hospital full of COVID. It costs you more staff. It costs you more supplies with PPE. You can't do elective surgeries. It's a net negative for the hospitals, and it makes them less money, and they lose out. So that thing is very frustrating. Getting said that we are being told to put COVID on death certificates is also absolutely false. Not a single doctor I know, and I know a lot of them obviously, has ever been told to put COVID on a diagnosis code. Now, we need to report when it's COVID because it is a obviously public health measure, and that is, you know, something that we need to go. Okay, so I'm going to stop here and just kind of scroll up through your comments just to see, you know, if there's any questions here that so someone says, thank you for the update. There's a talk that this disease is airborne. What's your opinion? Okay, I saw that news article that everybody's talking about airborne or not, and it sounded all sensational in the news media. It's actually not. We know that this disease is airborne, but it's not airborne like they sensationalize. So it is in droplets. So when you cough, when you talk, when you sneeze, it's in droplets hanging there. Those droplets are fairly big. If you wear a mask, you generally will not get it. And if that person that's coughing, talking, sneezing is wearing a mask, their mask is going to catch those droplets. When we talk about aerosolization, that's when it gets smaller and hangs in the air for longer. We know that it's been aerosolized for a long time, and it gets aerosolized with certain things, i.e. any procedure that will make tiny, smaller droplets that really disperse them in the air, those hang out longer, makes it easier to catch. So if I were to put a tube down someone's throat, intubate, we know that's an aerosolizing procedure. Certain ventilating mechanisms like a BiPAP machine will potentially aerosolize it, so we have to put a viral filter on the machine to keep it from aerosolizing out the virus. So this is nothing new. It's just the way that it's being presented in the media sounds sensationalized, like the WHO or the CDC is hiding this information. everybody in healthcare knows that it's aerosolized. And that is why you'll see different types of PPE or personal protective equipment that people wear. So for example, your average ER doctor, ICU doctor, nurse who are dealing with COVID patients are going to be dealing with every patient with an N95 and a face shield. That's going to get most of your big droplets. Now, when we start doing things like intubations and all of that, some of us will opt to go into a higher protective gear. So for example, I have a half-face respirator. I'm going to link down at some point, put this in a compilation of videos where in one of my previous videos, I show my half-face respirator. That's basically like a painting mask. I have a P100 filter on that filters out basically 100% of particles. So, and that is what I use if I have to do an aerosolizing procedure on a COVID patient. The other thing you'll see are either capers or pappers. If you've ever seen the movie like Outbreak, they are in those like white big get-ups, the whole suit with the little tube in the back. Those are pappers. Purified air, positive something. I always forget what it stands for, but basically it's a purified air device that puts positive pressure and it blows air into your mask so that you're not getting any viruses to you, and it's keeping it from basically getting any virus on you. So we use those, and then we try to put people in negative pressure rooms. Those are rooms that keep that aerosolized virus from spreading amongst the hospital when we're doing these procedures. So yeah. All right, let me see if there's another question, then we'll kind of continue on here. Sorry, I'm on my phone in my closet because it's the quietest place. Let's see. So Lori says, I'm canceling my trip to San Antonio. Stay safe. Yes, if you guys are coming to Texas, and I want our economy to succeed because it's terrible. I've had many friends and family lose jobs, but this is not the time in the next couple of months to come to Texas as a hotspot. So if you have your trips here, I would say stay home, stay away. Pretty much all of the South right now, I wouldn't go visit. So yes, I agree with that. Let me see a couple more here. Yeah, so yes, I agree. Michelle Kane, she said, I agree. I said beginning that face mask should be 100% fully mandated mask wearing. This should not be a political thing. I know mask wearing has become a very touchy political thing. It should not. And so now it is fine. You're able to get a fine and a warning here, and I'm hoping that is working. Now, I'll be honest, I do not leave my house except for to go to work and to come home. I have not been to the grocery store in months. I order all my groceries to be delivered at home. We never went out to restaurants, even when things eased up. When we did our 2-week vacation, we went to a state park, hiked, picnicked, and came home. So I haven't really been out to see if people are wearing masks. So yeah, it's hard to tell. Okay, so let's talk about what hospitals are doing in these high risk areas and how we're handling it. So you guys have probably seen on the news media like Houston and San Antonio, and they're talking about their hospitals becoming capacity. Arizona is another place. I have friends that work out there, and Florida is a big hotspot right now. When we mean we reach capacity, you got to realize we're still doing regular emergent surgeries and cases. So people with heart attacks and strokes are still walking through our doors. Those don't stop. But now what we're seeing is people have those plus COVID, or they just have really bad COVID. So we're still separating out patients as COVID and not COVID in our wards to keep from mixing and giving healthy folks COVID because it's a bad disease. And so personally at my hospital, for example, we had 2 big ICUs. Those are now full completely 100% of COVID. We have actually created a non-COVID ICU in a different part of our hospital that was not a normal place for ICU. So we're getting close to being at capacity of what we can handle on our normal basis with COVID before we have to even open up more. Now that's great. We can make a ton more beds. Our bed can expand like an additional 100 cases of COVID before we just can't handle anymore. But we don't have the nursing staff for it. And I think but if you don't have the people to take care of these patients, it's kind of useless. And this is going to be a big problem anywhere that's having a hotspot. And I think all my nursing colleagues and friends can agree with this, that they're already being asked to stretch to ungodly, unsafe numbers at most places that have a COVID outbreak. The problem now is, unlike in New York, where everybody could kind of come together and all go to New York and focus on that one hotspot, it's breaking out everywhere. It's California, it's Arizona, it's Texas, it's Florida. And so, there's only so many healthcare people that can come and help. And it's going to be harder and harder if all of our states are outbreaking all at once. And that's what we're seeing down in the South. So, yeah, it's rough. So I do think we opened up entirely too soon in this. I think the biggest thing that we did that was wrong was open up bars and continue to open up before we gave this virus several weeks to see which way we were trending. It's like they opened up and it was Memorial Day and then just it went to poop. So I would say that most other states should learn their lesson from us, and most people should look at what's happening in states like Texas, where we did open up too soon, because it's obviously we are an example of what not to do. Um, and I don't want my state to fully shut down again, but I would hope that people would take this seriously and understand that if everybody gets COVID and people are really sick and businesses have employees that have COVID, they have to shut down to clean up. They have nobody to work their business. It's going to shut our economy down regardless. So you can't open everything up and hope that the economy is not going to get hit. It's going to get hit. So we've got to be careful and calculated on how we open things up. And people need to be very careful and calculated on when they go out and how they interact with other people. Yes, your family member who is not sick can spread it to you if you don't live with them. That's something people seem to underestimate. And that's where I'm seeing a lot of spread is folks are going and having these big family meetups, 4th of July, Father's Day. And that's one big thing that people just aren't thinking of. They don't think their family is going to bring a deadly disease and spread it to 10 of their other family members. So, let's talk about a little bit of the course of how this disease goes. I've talked about this before, but I think it's important because people kind of, even my family kind of forgets this, and when they're looking at numbers. So this disease, you can get infected anywhere from like 3 days after exposure up to 14 days. Okay. So if you have been exposed to somebody with known COVID, you really need to stay away from people for 14 days. Okay. Somewhere in that time period, you're probably going to start showing symptoms. Now, the problem is a day or two before you start showing symptoms, you are highly infective. Okay. You can spread this stuff and not show any symptoms. And that is when we're finding it is you're the most infectious, and then that first day or two. So unfortunately, this disease is very easily spread in those early parts when you don't know it. So then you get it, and about 5 days in, you're going to feel kind of crappy, but it's really around day 10-ish that we see people start taking a turn for the worse. And the people we tend to see, no, this is not all the cases, but most of the cases, the people that we see that do the worst are people who are obese, people who are diabetic, people who are immunocompromised, and the elderly. Those are the big ones I'm seeing where people do really, really bad. Now, people with cardiac history, yes, can do badly. Pregnant women we have now learned that those folks are at higher risk of complication. So all these groups of people are very at risk. Oh, and pulmonary disease, obviously, people with COPD and asthma, they're at high risk. So those people about 10 days in start getting really bad. And if they're going to take a turn for the worse, that's usually when we see it. So usually about 10 days, I start seeing people come in. And they need oxygen, they need BiPAP, they need something to help them. And then in that 15-day mark is kind of when we start seeing people dying from this, if they're going to die. Well, some people we're able to get past that point, and then they get on a ventilator, and then they get over COVID, but they've had so many complications from the disease, like kidney failure, secondary infections from, sitting in the bed too long, clots, because this disease causes clots, strokes, and then they die several months later or several weeks later. Is it Nick Codera? I'm probably saying his name wrong. That the Broadway artist who had a really bad case of COVID. He was young. He lost a leg. He ended up having a stroke. He was on a ventilator forever. They just announced he died 3 months after getting the disease. So some of our deaths are going to take a long time to follow from this. The other thing that we cannot even count into COVID deaths, or they're not attributing, is how many people are going to die of heart attacks, strokes, sepsis and things that we could normally treat really well. But now I have a hospital full of COVID, a staff stretched thin, and those people are not going to get the care they need because everything's full. And those deaths should be related to COVID in some way or matter, but they're not going to be. And those are casualties of this entire epidemic. And I think not a lot of people talk about that. So yeah, our death rate is going to go up. So when people are saying our death rate isn't that high, they fail to think about the fact that we're lagging. We've just kind of bumped up over the last couple of weeks. Deaths kind of take a while to bump up after that. That's what happened in New York and Seattle in Italy. The other thing that I find interesting, and I had to look this up myself, and I read an article about this, plus I was talking to family members about this, is there is this feeling like the overall death rate has gone down dramatically. And although it is a little bit less than what it was, it's still high. And what we're doing is confounding the data, because if you pool all the data of all the US together, yeah, it looks like our death rates are low. But if you look, a lot of these places aren't having hotspots. If you just look at the hotspots data pooled together, the data doesn't look that great. The death rate isn't as low as everybody's touting, and it's not continually going down. So there is that's kind of, go before it dies. Okay, so basically a lot of people are saying kind of the same things that kind of agreeing. But yeah, guys, that is basically it. I know I've been a little absent on my channel, and I usually post a lot of stuff. I am going to get some videos up. I have tomorrow off, and I have some childcare because my meetings got canceled. So I'm going to get a video up for you guys tomorrow, not COVID related, for those that don't want to hear about COVID. I was thinking about doing an informational video about COVID, a little bit nicer and taped and edited for those for educational, because I know a lot of you guys like to take my videos and send them to family members. And so I kind of want to do something a little more coherent for that. But yeah, everybody stay safe, stay home, mask. We're in this for the long haul. This isn't going away anytime soon. So, yeah, and thank you guys for the well wishes. I am doing okay. My family is doing okay, but I definitely am drained when I come home, and so I don't have as much energy to expend on my hobbies. And so if I'm not there as much, that's why, but I will definitely keep you guys updated on what's going on. And thank you so much. All right, guys, I'll talk to you later. Bye.